talked about the electroconvulsive therapy. This is actually what we were discussing even with Herb, the ECT. So this is very important for y'all to know, because, you may see it again, I don't know. But when we think about the ECT shock treatment, these are with leads and currents, and it goes through the brain to cause a seizure. And patients may do 6 to 12 treatments 2 to 3 times weekly. People who are not good candidates for this are people who have had an MI stroke or brain masses. And this is like one of the last resorts of treatments which we talked about earlier, these type of electric current things. One thing we want to remember about the post-ECT is that we want to make sure that the patient has a patent airway, okay? Because usually what happens is they become very nauseated. And we want to make sure we give them anticholinergics to help with the nausea so they won't for the prevention of aspiration, okay? Then post-ECT, we want to make sure they're in a lateral position. And that's because, of course, if they throw up, then it won't be where they're laying on their backs and stand aspiration, a chance for aspiration. One of the issues after this treatment is that it can cause amnesia. You heard Dr. Shiver ask him this. And what you would do as the nurse, if the patient forgets things and asking questions, you want to reorient them. Okay, reorient them as you need it. Of course, anything post procedure, we want to do more vital signs. So vital signs, Q15 hours. And just make sure you have antiemetics to give to them if they need it. So the main thing with that procedure post is you want to make sure that the airway is good. They're not throwing up. Okay. Okay, so bipolar. Now bipolar, you can have a manic part and you can have a depressive. Now the thing about bipolar is you don't have to have both. You may just have mania and not have the depression. And that's how they actually break it up into the different bipolars, like bipolar 1, bipolar 2. I just want y'all to have a general idea about bipolar. Don't worry about getting so specific with them, okay? And this is a perfect example of showing you what happens on the mania side and what happens on the depressive, which we've already talked about doing the depressive disorder. Okay, it's practically the same, except we're gonna add manic. And again, bipolars can have manic and not have the depressive, or they can have both. So let's talk a little bit about the manic side. The manic side is where they have increased mood, and they can't control their mood. So a term for that is labile, L-A-B-I-L-E, a labile mood, can't control it. You're not able to follow stories because they jump from one subject to another. So sometimes for a speech, you may see that they have what we call punning, P-U-N-N-I-N-G. It's use of a word play. So they may say something like, time flies like an arrow. It's like, huh? But it's just a play on words. Now with bipolar, you weight loss, because during that manic phase, they may even forget to eat. And you wanna make sure that you give, if you have patients that's going through this, episode, make sure you give high protein finger foods. Try to give that to them, because most of the time, they're in such that manic stage that they just forget things, and they just forget to eat. They also have what we call grandiose delusions. Feel really important. Again, this is like feeling like I'm the Queen of England. It's a grandiose delusion. Now, these delusions, of course, are real to them. So we don't want to argue with them. And I think Herb kind of mentioned that in something he said, don't argue with them. That's their reality at that time. You just have to let them talk. And a lot of times for us therapeutic communication, sometimes with us just sitting there in silence and listening is what we would do. Because it's nothing, we can't change them at that point. So don't even try to argue with them. Just let them talk what they're talking. They become very distracted. And actually for nursing, that is a good point. Because when they get in that manic stage, we can kind of bring them back a little and calm them down by distracting them in doing certain things. So what I mean by that is, if, say for instance, that's not a good time while they're in the manic phase for them to be playing games with people. Because what happens when you're playing games? What happens when you play spades? We get serious about it, right? And it can send them really off into that manic phase. So we can distract them by saying, okay, come over, let's color this picture. And it kind of is a calmness to them. We don't want to do anything that they would have to rivalry, anything like that in a manic stage. No, that's not what you want. You don't want anything to overstimulate them. Nothing to overstimulate them, nothing having to do with competition, okay? What's that?
Whatever you have patient.
Rock, paper, scissors.
Oh, rock, paper, scissors. That's what you were doing?
It was a mistake.
So with them, we want to make sure that we can de-escalate them from the mania, okay? We want to monitor the increase in risky behaviors, okay? Because in this manic stage, they can get into some risky behaviors. This is at the time where with bipolar, this is even at the time that people go through this manic phase. Some people will just spend all the money they got. Just in a manic phase of just doing things, they'll just spend all their life savings. And that is true. I've heard of some people doing that. That's why people with bipolar issues, you want to make sure that you have someone to help you with things like that, that's over to help you with your finances. Because when they go through that manic phase, sometimes they can just go through all they got. For what reason, I don't know, but that's just can be part of a manic phase. And they also can be very promiscuous in this time. And this, of course, is debilitating to a relationship during this manic phase. So, of course, for safety, aggressive behavior, we don't want them to get into aggressive behavior again with, say, distracting them into something that kind of calms them down instead of putting them into rivalry positions or competition. We don't want that. We don't want any type of overstimulation. Then we want to make sure that we tell them about consequences of behavior, because sometimes during that time they can do, like I said, some crazy behaviors. And we want to be firm with them. So say for instance, if they're in the hall and they're yelling to the top of their voice, as a nurse, I'm able to say, okay, stop hollering, or I'll call somebody to come help me. Something that's like that, to kind of calm them and bring them back to reality. We can offer choices when appropriate. And after we talk with patient, we need to make sure that make sure that the other staff is in agreement with how we're gonna be consistent with the care for this patient. Because in the medic phase, they are very manipulative. So we wanna make sure that all the staff knows the boundaries and limits and that, we're consistent with it. So many, clients can, which we said this, avoid arguing. Sometimes they can say things to people and know that this is not a personal put down, it's just part of that illness. So sometimes they may say something ugly to us as the nurse, but just like any patient, we can't take it, just take it with a grain of salt, because, you know, it could be part of the illness that's causing these issues. So for bipolar, we use mood stabilizers. Lithium is a big one that's used. 7 to 14 days before it becomes effective. Here we go again, 7 to 14 days. And usually when they're started on lithium, they need to be on it for the rest of their lives. And also with lithium, we don't want toxicity. So there is a lab value, and the range for lithium is 0.6 to 1.2. That's the normal value. If it gets greater than 2.5, this can be a medical emergency and even lead to death. So when patients are on lithium, they need to have their blood drawn routinely to make sure they're in range. Again, the range is 0.6 to 1.2. It's important to have a consistent salt intake, because if we decrease the salt levels, that increases the lithium intake. So for instance, if you're on lithium, it's not a good idea to be on diuretics, because what does diuretics do? It gets rid of the salt. And so that's gonna in turn increase the lithium intake, and that's not what we want. And we also wanna make sure that they drink fluids. We wanna make sure they drink 1.5 to 3 liters of water a day. Again, like Herb said, it's a good thing he didn't like alcohol and drugs. Avoid alcohol, all of these meds just about. We wanna monitor the EKG renal function on this med, because it can cause nephrotoxicity. Anticonvulsants can be used to decrease mania and stabilize moods also. There is a greater adherence with these type meds. That lithium is harsh. So you see a greater adherence with these type meds. Side effects for this is a rash. It can cause a rash. Lamictal, which is the lamotrigine, can cause Stevens-Johnson syndrome, which is a severe rash. When we talk about valproic acid, which is what we know as Depakote, it can cause liver damage, abdominal pain, and jaundice. So with this drug too, with this medication, you also want to look at the range of it. So we know for, valproic acid is 50 to 125 micrograms per meal. And then for the carbamazepine, which is the Tegretol, is 4 to 12 grams per meal. And when we talk about the carbamazepine, which is also Tegretol, some side effects of it is what we call blood dyscrasias. This includes anemia, leukopenia, thrombocytopenia. So again, we want to monitor labs for that. Okay, so this is where we actually talk about schizophrenia. I think we didn't talk about it before, her, but here we go. Now, with schizophrenia, there is a disturbance in thoughts, speech, moods, social behavior. What % of the population has schizophrenia? 1% of the population. It is shown to, during late adolescence to early adults, 16 to 25 years old, and it can peak in men from 15 to 25. So with Herb, he was 23. Women, it peaks from 25 to 35. I just want you to kind of get an idea about it. Now, it's funny with homeless because 21% of the population of homeless people have schizophrenia. So we know being homeless is one of those environmental things. So what is it that can take them to the point of being homeless, of having schizophrenia? I don't know. Cause for that is unknown. The goal with this, we want to prevent relapse. So we want to make sure patients are taking their medicines and on their treatment plan. Now, when we look at these symptoms up here, this is showing you positive and negative symptoms of schizophrenia. Now, the positive symptoms are symptoms that should not be there, but is. And the negative symptoms should be there, but is not. So with the positive, we see that they may have delusions, which we've talked about, hallucinations, catatonia. Anybody know what that is? Catatonia is posturing. So they can be in a position of posturing and can stay there for hours. It's called catatonic positioning, or catatonia, has to do with the posturing. For as negative, we see that flat effect, which Dr. Shiver said he has that flat effect. That's a negative symptom of schizophrenia. It's harder to pick up on, but the negative is harder to pick up on, but it can go unnoticed. But for as a negative, they have the flat effect, show no emotions. Allergia, decreased speech, avolition. So to remember the negative symptoms, think about the 6 A's. Affect, allergia, avolition, all those A's. They may have a reluctance, of course, to perform everyday tasks like ADLs. So we see with Herb, he tries to stay on task of doing his ADLs, which is very good, very beneficial for him. So again, you know, they may have auditory hallucinations, may hear voices. They may also say words, when they're talking, they may sometimes do what we call a word salad. And that's just disorganized words. Like car, fan, sticky, school, phone. It's like, huh? Disorganized, just word salad of words, just words. And the catatonia, we said, was no movement or bizarre posturing for long periods of time. Make sure box 66.9 and box 6610 in Saunders. I don't know what that is, but put that on your, in your notes to look at, okay? For its treatment, of course, therapy, medications, we can have, vocational training, because again, with schizophrenia, it's hard to hold a job. And we see with Herb, he wasn't able to have a job because of this disorder that affects people. For its health promotion, we want to educate them on how harsh these medicines can be. And of course, there we go, alcohol. We can talk about alcohol all day. These alcohol drug use can make these symptoms even worse with taking this medicine. So let's skip and talk about first generation antipsychotics. This is a haloperidol, which we're very familiar with, flurfenazine, which is the prolixin, and chlorpromazine, which is the thorazine. The action of this is it blocks dopamine receptors. Now, this type of medication is used to treat the positive symptoms. So what were those positive symptoms we just talked about on the other slide?
Hallucinations.
That's what it's treating. Okay, it's treating the positive symptoms, not the negative symptoms. Now, with first generation antipsychotics, one of the things that we may see is extrapyramidal symptoms, EPS. We're gonna talk about that on the next slide, EPS. But some things I want to tell you about these medications, you see the ones that has the asterisk beside them? These are injectables. We moved up a little bit. Some of these medications are injectables. So it means they can, have it for, maybe get the injection and good for 2 to 4 weeks with it. But these first generations has harsh side effects. It's actually not the first line of treatment anymore because the medications are so harsh. And again, they're harsh because they cause EPS, the extrapyramidal symptoms. So let's look at some of these. Now, this picture you see of this patient is actually a demonstration of acute dystonia. The patient can have involuntary contractions of their muscles, of the extremities, their face, their neck, their abdomen, their larynx. And usually we'll see acute dystonia close to that first dose or an increase of dose. We should be, most of the time you may see it if it happens then. There is a reversible antidote that we can use, and that's benztropine, which is cogentin, benztropine. And we can use diphenhydramine, which is Benadryl. You want to make sure that if you see symptoms coming, that we at least give it IV or at least give it IM. Because if you're on a psych unit, 9 times out of 10, they're not gonna have an IV. So we wanna make sure we go ahead and give it to them IM. And then, why would it be that we don't wanna give it PO anyway? Why would we not wanna give it PO? Cause what's happening with the acute dystonia?
There's language.
Yes, so we don't want that to happen. And also, we can see Parkinsonism. These are like the physical symptoms, people with Parkinson's, the shuffling of feet, those type things we can see with this. This is also reversible with benztropine and diphenhydramine. So the Parkinsonian, we talked about the shuffling gait, drooling, slow movement, tremors, stupor posture. Akathisia is a psychomotor restlessness. So akathisia is where it's like they can't be still. They've got to be in motion all the time. You just got to, it's like ants in their pants. They can't be still. And this can come on the first 6 weeks or an increased dose of this medicine. Now, all of those symptoms can be reversible. But tardive dyskinesia is not always reversible. So what do we see with this? See the smacking, puckering of lips, eye blinking, grimacing, and twitching. So with the first generation, one of the things that we want to do is to give the lowest dose. Give the lowest dose. Now, if you go out on the module and you look, I had a section there that had different type of scales and tools. One of those scales is the AIM scale. And that AIM scale, if you were to look at it, what it's used for is to try to prevent tardive dyskinesia and those EPSs, the symptoms. So what you're doing is measuring and assessing movements. And these are kind of used when they come in for follow-up to make sure that they're not experiencing or about to experience any of the extraparental symptoms. Neuroleptic malignant syndrome. This can happen with antipsychotics. And if you want to think about it, this is like serotonin syndrome's cousin. Because some signs and symptoms you're going to see here is muscle rigidity, altered mental status, autonomic dysfunction, and you can also see hyperthermia, the temp going even as high as 108. Yes. So with these medications, you want to make sure that you assess for their vital signs, for this temp, make sure it's not going up. Make sure we keep them hydrated. And then for the muscle relaxant, we use dantrolene, 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 as the muscle relaxant to help.
Does this happen with surgery too?
Surgery,
What is the side effect of?
the NMS,
That's the one that hypothermia, that's what we treat.
yes.
cause that's what you treated it with too, eventually, I was like,
Yeah.
So are all these drugs gonna be on test, or is it just like what you mainly see being given? Because
Ask me
this
that
is.
again.
Cause
Are these
whew,
drugs
Lord
gonna
have
be on the
mercy.
test?
Yeah, are all these drugs gonna be on the test, or is it like what you mainly see being given today? Like,
Okay,
MRI.
so the way I can answer that is I may use one of those drugs, or I can use a med for a question.
Cause I feel like I'm just gonna have to go home and make.
But what I'm gonna tell you is that the drugs that I use is gonna come from what's on your PowerPoint. I'm not going out and pulling another med, if that makes sense.
do we need to know their mechanism of action for each one also?
Like increase,
Yeah. Or like the SSRIs.
you kinda need to know that,
Okay,
but it may not like be a test question,
okay.
if that makes sense.
Cause I like, yeah, it is.
Okay. Cause I feel like SSRIs,
That one kind of
what
tells
is it?
me.
Yeah,
But some of them have two, like they do two different, when you get them out.
yeah.
Y'all wanna get together this weekend to study?
Yes. No, I'm actually done.
But again, your medicines, learn, so let's go back to the, losing my thought, it's getting late. The first disorder we talked about, what did we talk about? The benzos.
Yeah,
Okay.
and the lamb.
Yeah, so pretty much remember Lamb, you know, the pounds and what disorder it applies to. Cause then on the test, if I use alprazolam, then
You
you,
can have depression or anxiety.
yeah. But I'm not gonna go and get like one of these meds that's just come out yesterday. I'm going strictly, if I use a med, it's gonna be, I promise you, it's gonna be from this PowerPoint. That's the best I can do.
Thank you.
So,
Okay.
yes,
We
That
have
makes
to know all
sense.
the meds, yeah.
Oh, it's a lot more.
Ugh.
I mean, it's a lot more meds.
That's okay, we can memorize, guys, we're smart, we got this. Thank you.
The benztropine is used to reduce EPS in patients taking antipsychotics. So benztropine is also used, but with like benztropine, just know that it's used to reduce EPS. Benztropine, okay? They will have, with this medication, it may cause dry mouth, constipation, urine retention. The second generation antipsychotics. Now, really what I hate about these, y'all, is the generic names. These names are crazy. If it was any way you could know Abilify, Zyprexa, I could learn it better just from the trade name. But for purposes of your test and the NCLEX, they're gonna use the generic name. So that's why we have to use generic name on your test. Now, these medicines can cause metabolic symptoms. So when we talk about metabolic syndrome, these drugs can cause heart disease, stroke, diabetes, those type of things. So we wanna make sure that we check labs before starting this med and annually, so we can just make sure everything is okay metabolically. And second generations are really the first line of treatment for schizophrenia. Because what did we say about the first treatment, the first generation? They were very harsh. So second generation is basically the first line treatment because of that. With these, we can see less relapse of these medicines. We can see less relapse, because number one, they're a little easier to take than the first generation. So people are more will adhere in taking them. Now, one of the second generations that I wanna talk about is clozapine. Now, this med, I want you to remember, because this med can cause a granulocytosis. So we see a decrease in the bone marrow. And there is a decrease in the blood products, so we may have risk for bleeding and infection. Also, a big thing with this medicine is that it decreases the WBCs. And usually this is what's affected the most. So in the case that a patient is on this medication, what is it that we want to monitor?
CBC?
Yes, WBCs. We want to monitor the WBCs, the white blood cells. So that's basically what I want you to know about that drug. So with schizophrenia, relapse prevention is the key. Again, to make sure they have a good support system. Make sure they're able to try to do their ADLs. Early treatment and control of the symptoms is a big one. So basically, this is really what Herb said about his schizophrenia. Personality disorders. Now, personality disorders are kind of strange to me, but everybody has their own personality, right? And sometimes, because of that, it can be put in a clump of having a personality disorder. So there is no medication per se to treat personality disorders. The only thing you can do is to treat them with a medication of any symptom that they're having in that personality disorder, okay? So when we look at personality disorders, people who have this disorder causes dysfunction in relationships. Some risk factors are hereditary, temperamental traits, previous trauma, and again, the adverse childhood events. Okay, so let's look at the clinical picture. We have cluster A, cluster B, and cluster C disorders. Now, cluster A disorders is the personality where the person is seen as odd. They try to avoid, having a relationship, interpersonal. They're just different. And they often can have that paranoia or paranoid side of them where they actually don't trust anybody. They don't trust anybody. When we talk about the cluster B disorders, they can have emotional reactivity, poor impulse control, and very manipulative. They can act histrionic, which means that they want to be the center of attention. They're the center of attention. Y'all know some people like that? Nobody else matters but them, center of attention. Narcissistic, it's all about them, self-importance, grandiose. They also can show antisocialism. And what I mean by that is they disregard others they interact with. It's always that they're looking for a gain out of their relationship. They want to gain something. So to me, an example of that is like serial killers. You know, how they get a relationship with someone to kill them later on. That's just an example of that. Borderline personality disorders. They either see you all as good or bad. You're either good or you're bad. These people have unstable, intense relationships. And then they are really the scariest as far as attempting suicide, because they may try multiple times to commit suicide. Cluster C. This has to do with obsessive compulsive, avoidant, dependent. So these type of people are perfectionists. They follow the rules. And for as avoidant, they're social withdrawn because they fear being rejected. They don't want to be rejected. So they'd rather just avoid people because they don't want anybody to reject them. And for as dependent, they lack self-confidence. They have a decrease in self-esteem. And these type people are at a higher risk for abusive relationships. Because you think about it, they don't have any confidence, they're low self-esteem, they could easily be in an abusive relationship. And then when we look at this picture, it just shows you the clusters. I just thought that was a neat little thing to show you how these clusters are for that. So far as interventions, for safety is a big one. Be consistent with these people who have these problems. You, for as the medications, you treat the symptoms, not the personality. And for as therapy, that's the main treatment, it's the most effective. All right, so substance abuse. Now, on this one, when we talk about substance abuse, there are 10 substances that's considered for as abuse of. We know alcohol, caffeine, cannabis, inhalants, opioids, sedatives, hypnotics, hallucinogens, I don't think I said that one, and anxiolytics, which mostly is your benzos right in there, and stimulants. So when we look at, substance abuse, it's mainly because habitual use of these medications. So how do you assess people for possible addiction? Well, there is a tool that sometimes when you're doing your history and physical on patients, you will ask them, or, do you drink alcoholic beverages? If so, how many? We see those on history and physical papers all the time. Because what it's trying to do is see if you're actually, using it for, if you're abusing it. So with these, just make sure for as antidotes, for as overuse of substances, for as antidotes, naloxone is one, Norcan as we know it, is for opioids, and flumazenil, which is romazicon, is for benzodiazepines. It's important to know those antidotes, because anytime, like on a test, they can ask you what's the antidote for medicine. For a medication. Okay, so the CAGES questionnaire, this is just something just for you to know, because when you start working, this is really when you're gonna, know about the CAGES questionnaire. But this is pretty much, questions that it's gonna ask you to see if there is a possibility that you do abuse, drugs or substances, alcohol or whatever, okay? So this is just seeing whether you're prone for it or not. In the case, if a person starts going through withdrawals, then we use what we call a CWA screen. CWA, which helps us determine what we need to give the patient when. Okay? So with the CWA, what it is Clinical Institute Withdrawal Assessment. This is the most used to see if we need medical withdrawal management. And then in the case, if we do, then a lot of times, like I know at East Alabama, they have a protocol that if it gets, whatever the number is, however this scaled, if it's a high number, then it says we need to start using that withdrawal protocol. Okay, so then we'll start using it with how that protocol is laid out. It actually has like 10 questions on this protocol. And the score can go up to high as 67. But in that case, we know that we wanna start this protocol for that patient. When you see withdrawal, it's actually gonna start usually 24 to 48 hours after they're in the hospital. Because right before I come in the hospital, I've had my drink, I'm fine. But if I'm staying in the hospital a couple of some days, 24 to 48 hours is when you might start seeing that withdrawal time. In some places, because the physician know their patient so well and know that they use alcohol, some physicians will order that the patient can have a beer once a day. In some places, and I know when I was on the floor, work on the floor by the bedside, they would do that a lot, but that was like old school docs back then. But they would do that. So for some signs, you will see hallucination. Those vital signs will start increasing. You may start to see them tremoring, shaking, and seizures and sweats. And has anybody ever seen a patient to actually go through true withdrawals?
Yes,
How does it look?
it looks awful.
That's very sad, you know.
It is awful. It's like your worst nightmare. So again, severe form of alcohol withdrawals can peak from 24 to 96 hours and it can last 2 to 3 days. Here you can have electrolyte imbalances and cardiac issues. So again, with this protocol, if we see that a patient is going through withdrawals, then a lot of times we'll start them on different things, different medications, to make sure we try to get this under grasp. You wanna make sure you check your patient often, monitor those serum electrolytes, cause if they're going through withdrawals, 9 times out of 10, they are out of whack. Minimize their anxiety. We can give them some benzos. And with this, we can see seizures, which I've said, and we just have to keep that patient supportive and try to keep them as oriented as we can until they get out of it. So again, here on this slide, we see that we may start them on some benzos. Chlorodiazepoxide is, which is Librium, that's the main one, most of the time. I mean, these are the ones that's used, but we see that used a lot. We also wanna make sure we start them on an anticonvulsant because this would put them, because they are at higher risk for seizures because of this. And then also start them on some vitamin replacements, because with alcohol, vitamins they don't get much vitamins, so we need thiamine, B1, we'll put multivitamin, start them on multivitamin. So know for the withdrawal delirium medications that they can be started on benzos. That's a big thing. And what do we know benzos for? For as a disorder? Yeah. Now, once we get them out of the, withdrawal session and say they're getting ready to go home, this is like a treatment that we want them to kind of be in as they get out of the hospital. Okay, a lot of times Alcoholics Anonymous is a 12-step program, but these are just medications that, they may be started on, once they leave, the hospital. as opioids, the one thing we see about opioids is that a lot of times patients will be started on, say, 5 milligrams, and instead of them being on the 5 milligrams to allow it to work, they'll increase their own dosage. This is very bad to do because with opioids, it's like the respiratory system didn't get the memo that you're doing this, and it can lead to respiratory depression. So we saw, I think it was on one of the other slides, but the antidote for opioids is naloxone. So when we look at withdrawals, again, safety is very important. Safety, that's all I'm gonna say on that. And of course, the last resort is what, if we need them? Restraints, which we try not to. Okay, so let's switch to abuse right quick and see what we got about it. We know that for as abuse, symptoms are different with each type of abuse. So for as physical, we may see things like cigarette burns, we may see broken bones, we may see bruises. Emotional is talking down too. And then sexual is inappropriate, no consent. Also, we can see financial abuse, and that can occur especially when you have an elderly patient and you have a family member who's trying to pretty much take their money because they're vulnerable, being an elderly person. We can see that. And then for as neglect, for as physical, we can see that the person may look malnourished. They can have bed sores. And then educational neglect is school age not receiving education. So the point of parents not even taking the child to school. It's neglect. I wanna give you some stats, just listen. This is not on the test or anything, just listen. 25% of children will experience abuse. 80% of child abuse is neglect. 1 in 3 women are sexually assaulted by 18, and 1 in 5 men sexually assaulted by 18. Just to give you some stats, that it is real. So these are some victims who, can experience these things. Special needs, people with mental health disorders are more prone to these things happening. See, pregnancy and lack of self-confidence, feeling trapped. A lot of times the abusers we see can be, use alcohol or substance abuse, or they could have a history of being a victim of abuse themselves, and it's like a cycle. And again, the abuser can be, have a mental health disorder too. So again, with, trying to just see on here, is there anything that we need to, for his test? I'm getting down to the end and I'm trying to help y'all out.
I know you're tired, we tired too.
I know y'all are. Been here since what, 9 o'clock, I'm about gone, what time is it?
Almost now.
I'll be getting ready to get into bed by now if I was at home.
Right?
Just read over that slide, nothing,
No, it,
nothing on the test about that, really. But let's look at this one. I do want you to know about, of course, we talked about neglect. How would you know, what are some signs of someone being neglected? I do need to make sure that you know of some physical abuse signs. Make sure that you do know that. And also, make sure that you know, which I said earlier, that we are mandate reporters for these issues. So anytime we see any type of neglect, any type of physical abuse, sexual abuse, or emotional abuse, we're mandatory, reporters for that. So say for instance, if you, I'm just saying, for example, you have an admission on a unit anywhere, and you see that some of this can be possible, then you are a mandatory reporter, which means that I would get everybody involved that need to get involved to make sure this is reported, which means that may be to my, the nurse in charge nurse, till it gets to the manager, to make sure these things are reported. So far as, elderly abuse, all of this kind of falls in the same thing. Poor hygiene, unattended medical care for the elder, things like that we need to report, especially if you work in, home health. Some of you may do home health nursing. So you may see some of this out, what I call in the field of seeing these things, with the elderly. Or not only just the elderly, it could be with kids, whatever you're doing, but just make sure that you keep this in mind to report these things, and then knowing the symptoms of these things will help you with that. So far as nursing interventions, again, report it. Make sure that you document things really well. That's important, because if you didn't document it, you did what? It didn't happen. Okay, so make sure. You wanna make sure you establish trust, which is very important, because if you establish trust, then hopefully that person can tell you what's going on, to the point of you knowing what type of help to get them. Also, the priority at that time, if you see any type of physical problems that need to be addressed, we will want to go on and address those things first. Now, let me ask you this. If you had a situation where you have an abuser, okay, so you have a patient that's coming in, and then say their spouse is the abuser, and they're with them, okay, and you suspect that the spouse could be abusing the patient some kind of way, because number one, the patient may not even answer you questions. It may be the abuser answering all the questions. So in that case, and if you pick up on that as being an issue, what would you do?
ask me to step out while she checks the computer real quick.
How about if I don't step out?
You're not the patient, so get out.
How about you gotta take her to the bathroom to get a urinalysis?
Take her to the MRI.
Okay,
You
but
gotta take
still,
some-
I'm still an abuser. I feel like that I need to be in the room because it may be some questions she's not able
I'm gonna
to
call
answer.
security.
Or we need to get somebody else involved to
Yeah,
see,
because
yeah.
at this point, sir, you're being a disturbance.
True, true. But how do we handle that in the way that it doesn't escalate is the thing. So I want you to think about situations like that because sometimes you can get in a situation like that. So then what do you do? If you're on a unit, then, again, that's what the charge nurse, that's what the manager's for. You wanna escalate it up to make sure we do what we need to do for that patient, okay? All right. So this is talking about cycle of violence, and I just want to hit on this because when we look at this, people go through abuse and violence. It's just a cycle. It can even be a generational cycle of violence. But when we look at it, there are certain type of things that happen. First, there can be the honeymoon phase, okay? So here it is, the honeymoon phase. I'm saying I'm sorry. I'm gonna give my significant other a gift. We're gonna make everything okay. That's the honeymoon phase. And then what's happening is the victim is trusting that it's about to change. It's gonna change. They're doing this, it's gonna change. Then we get in that tension, cycle where minor things start happening, okay? The abuser may be edgy, may do minor slapping or anything like that. And the victim though becomes kind of tense, helpless, they accept the blame, okay? And then it comes with the serious battering, where it becomes unbearable, okay? And the victim may be covered, it may cover injuries. They may look for help, that's what we hope, but sometimes that may not happen. So the reason I brought that up is because with those, the cycle, and if anyone talks to you about that cycle or things that can occur, one thing we need to be mindful of is sometimes the patient may not want to get out of that situation right now. So in that case, what are we thinking to myself? Are you crazy? You let him hit on you and do all these psych things? But again, we need to put ourselves aside. But even in that case, then what we would want to do is to give them resources. Give them resources so the patient can make their decision, and it doesn't seem like you are judgmental, okay? But you are supportive. To me, that sounds really crazy. But again, that's what you wanna do, okay? You wanna make sure that that person, that we give them resources that they need. So we're not judgmental. We wanna be supportive. We wanna care for the injuries that could have happened. Maybe establish a safety plan for them, but we would wanna give them those resources. Yes.
I just wanted to say, for not being judgmental, for trying to leave like a bad situation, is, leaving like abusive situations, that's usually the most dangerous time. So sometimes, you know, especially like a patient, they could have actually tried to leave prior to that, so they also they may be afraid of trying to leave again. So
Right.
that's usually when things increase and things are more dangerous.
Right,
Yeah.
right. That's a good point. So it's really a sticky situation. It's sticky, but for us being nurses, that's what we want to do to try to help them, okay? The last thing I wanna just, tell you, we're done with this PowerPoint. The Joint Commission recommends hospitals to use a survey to try to screen patients upon entry, for abuse. So when you do your history and physicals again, when you start out in the real world, you're gonna have a lot of things for us on that history and physical when you admitted patients. different type of tools, different type of screens that's used, to try to help with those situations. Yes,
Okay, so I know on the practice or SE that we took at the beginning of the semester, there were a lot of questions on neglect and abuse. So like, a lot of them were like, what would you do first? And I remember it saying, take pictures, report it, and then like there were a bunch of different things like that. Like, just like knowing how to test NCLEX and SE style, would you always choose report first for highest priority?
I can't say always, but yes, most of the time. Most of the time questions are like that, want you to pick that.
Cause it was like take pictures and then send them to who needs it, something like that. It was like.
Would you take, I think they're separate, but would you take the pictures first, or would you report it first? I think that's where my head was at on that test, if I can remember.
It was really weird. It was like take pictures. I didn't think that
It
was
was
appropriate at the time.
Well, see, I can't really answer that, cause it depends on how that question is worded.
Oh goodness, I can't remember.
I know, it's crazy.
It was something like that.
Cause one word, y'all know, one word in a test question can change the whole question.
Yes.
It was suspected abuse, and I think it was like domestic, right? I don't think it was, like, I think it was a husband-in-law, I don't think it was a child.
Uh-huh,
There was also one that was about overuse, I was very confused.
okay. Yeah. Far as on your test, far as that, oh gosh, I can't remember it. Far as adult abuse and stuff, I may have, like, maybe, I'd say 2 questions. I can't remember, but it's like maybe 2 questions that have to do with that. So again, y'all, with the studying for the test, for my portion, if y'all pretty much just go through, I don't wanna tell you just to look at the PowerPoint, but just go through my PowerPoint. I promise you, and I may not even need to tell y'all this, but I'm just gonna be transparent with you. Every question that I'm asking you, I've said something about tonight. So again, if you go through that PowerPoint and go through what I said, then you shouldn't have trouble with my question. Does that make sense? Now, this is still good. I want you to still read those chapters, all right? Because we can't cover everything in class. NCLEX, HESI can ask you anything, so you still got to be well-rounded in all the information, okay? But I promise you, I will not lie to you, all your test questions have come from something I've said in the PowerPoint.